Thanks, Paul. I actually love this topic. You gave it to me because it kind of made me think about how I approach patients, because I do all the above procedures, and it's sort of, there is a decision-making, at least algorithm for me as to how I approach these and why I do, when I do what, right? So I think it kind of made me think, but let's just start with the very fact why interbody fusions, right? Because we all know you can do everything posteriorly, but if you're doing MIS, your fusion is into interbody. I think that's a given right there. If you're going to do any MIS technique, you're relying on interbody fusion. So that's a given. But then the most important thing we want, what do we want out of this, right? We want a fusion. You got to create and maintain sagittal and coronal balance, and both are important there. You also want to create stability. And this, I think, is the most important. It has to be easy to use for the surgeon. It doesn't matter what it is, but that surgeon should be comfortable or proficient at doing what he's doing. And I'll be the first to say, I don't think it makes a big difference what you do of these three. There are nuances as to where you can get more leverage out of one technique over the other. But I don't think you'll ever find anywhere one is significantly better than the other. So we'll go through that in a minute. So I threw this table together to kind of summarize a lot. We'll spend some time on it. I know it's full. But I want to show the surgeon comfort, right? We're all used to TLIF, PLIF. Most surgeons, you know, open posterior, you get down there, you know the area, you know the anatomy, and people are more comfortable doing that. Today, more and more are getting comfortable with the lateral interbody fusion at the top, right? And then ALIF now is kind of getting only put two because I think this is definitely less than trans-psoas. Pre-psoas, people are kind of getting comfortable. And then ALIF, again, the only reason I did that was you need a vascular surgeon. And some patients, vascular surgeon is not there, so you may not have access to do an ALIF. That's why I only put three. But I still think in terms of comfort, I still think today posterior people are most comfortable. No visualization, obviously, you see the nerve clearly. You clearly do not see the nerve in any of these three procedures. Access, again, access is pretty good. It technically sometimes can be difficult to get good access into the canal and down and do your job. But again, lateral and ALIF, the access getting down there, you got to be proficient of getting down there to do the job. Certainly easier to get down there on a TLIF lift than in a lateral or an ALIF unless you get proficient. So I kind of put 1+ less there. Same with the ALIF because you need a vascular surgeon. You don't have a vascular surgeon, you're kind of restricted. So if you have a good vascular surgeon, that makes your ALIF better. And those of us who have good ones take this for granted. But having traveled and spoken to a lot of people, some areas just don't have a good vascular surgeon. So that turns, so you may not be able to do the ALIF that you'd like to do. So you got to look at doing something else, right? Vascular issues, obviously, hopefully you don't get that with the TLIF, that'll be a bad day. But lateral, again, obviously you can have it. ALIF, you can have it. ALIF, I think you definitely have a much bigger chance. We start mobilizing vessels, doing 3, 4, and 2, 3 ALIFs. I mean, you got a good vascular surgeon, sure. But you're looking at vascular problems a little more, I'd say, if you're doing that. Interbody height, again, TLIF, are not going to give the same height that you're going to get with the lateral or with an ALIF, right? And the ALIF, I think, most of us would get really, really good height. We were used to it. The ALL's resected. You get really good height. So that's something to think about. ALIF gives you the best height. Those of us who are proficient can say probably we do it also with lateral or ALIFs, right? Foraminal height, same thing. TLIF can get it to you, but not as good. Because you get good height, you get good foraminal height too. And again, ALIF can give you good foraminal height as long as you kept that open. But why are these important? Come in a minute to make those decisions of what you need. Neural decompression, to this day, even though indirect decompression, I think a lot of us have become more used to and started using it more and more. There's no question that you do a TLIF, you're directly visualizing doing a good decompression, and I'll still give it 4+s compared to this year. And I think if you're starting off early, you may have some trouble with indirect decompression. But it is real, it does happen. I'd say 97% of patients to 98 get a good indirect decompression. Radiculitis and nerve injury, no question, and TLIF and PLIF is more prone to it. You're right there. Don't dissect the nerve. Don't retract the nerve. Try to stay away from it. I think you'll have less of a problem with radiculitis and nerve injuries. Obviously, with lateral, I put that only because of the trans-psoas and maybe some lumbar plexopathies. I think a little less with these two in terms of nerve injuries. Single position, clearly TLIF is the best single position 360 surgery we do every day. We get so carried away. It's the best single position surgery. Now, can you do single position? Yeah, well, sure. We just heard about it. You can certainly put screws from the back. Posterior muscle injury, clearly TLIF, right? You're in the back, you're dissecting. Even if you're doing MIS TLIF with the tube, you are damaging that muscle to some extent, and the sooner you can do it, less retraction, less ischemia. Obviously, no posterior muscle injury here. Psoas injury, clearly nothing on TLIF, but certainly more so with trans-psoas, a little less with OLIF, and obviously ALIF you don't. This, I think, becomes really important, segmental lordosis. On average, you get, we showed that way back in 2005, you get about 7 to 8 degrees of increase of TLIF or segmental lordosis. Sometimes you're as low as 6. Clearly, with lateral and OLIF, you're getting a lot more. They're getting at least about 12 to 15 degrees, depending where you place the cage. More anterior you place it with the lateral approaches, you get a better lordosis. But ALIF clearly, without a question, gives you the best lordosis. So if you're trying to achieve or create that, remember that. Then ALIF gives you a much better option of creating a good lordosis. Can you do it with the lateral? Sure you can, but I think ALIF is better. Coronal balance, again, I think TLIF, you're not really looking at getting coronal balance. People would say put it on one side, you get a little bit more. Really, I don't buy that. TLIF doesn't give you as much of that. Laterals clearly help you with that. ALIF, again, is the best. You resect the ALL, you put a big footprint spacer in there. You, with ligament taxis, correct the coronal balance a lot. So ALIF, again, is a good one, especially at 5'1", to correct that. End plate preparation, TLIF and PLIF, pretty good, but not that great. You only get much better with laterals in end plate preparation. ALIF, again, is the best because you're really looking at it, and I think you get great end plate preparation if you really were to see, as opposed to laterals. Again, something to think about, because you get much bigger surface area of control and much better discectomy. Implant size, clearly, TLIF probably the smallest implant size ever, but still we get it in, and it kind of works. So we want to talk a footprint, clearly the smallest footprint, but it does work. And laterals, clearly much better footprint. ALIF has the best footprint. So again, if you're thinking of that, stability, put that in place. Again, standalone. I think TLIF obviously cannot do standalone. Laterals, I personally would not advocate standalones. Very, very, very selective for standalones for those patients. ALIF, you can. I mean, you got a pretty stable spine. ALIF with good anterior fixation, you can do standalone, and we know that works out pretty well. Fusion, interestingly, is actually the same across the board. They all have pretty equivalent fusion, with the laterals and ALIF maybe a little more than the TLIF. But fusion results actually are equivalent. So where does all this come from, right? There is data, and unfortunately, every time data comes, always meta-analysis. I hate meta-analysis. It's garbage in, garbage out. And that's the only problem. But Ralph is a phenomenal. Ralph Mobb is a really good friend. Sydney, Australia, does great research, good work. And I think at the bottom line, there's a meta-analysis across. I think he had about 36 papers, ultimately narrowed it down. Similar fusion rates. ALIF clearly better height, better lordosis. Interestingly, TLIF, he had a better ODI, and I'm going to think that, really because he probably is a very good TLIF surgeon, and then switched to laterals kind of later, and this is 2015, so it might be kind of learning curve. I'm going to guess that. I can't explain that. But obviously, PLIF had the greatest blood loss, and complication rates are pretty similar across all these publications, right? So he doesn't, so again, interestingly, Ralph is so good, he puts the same paper out 2 years later. It's the exact same paper, so it actually works. You just keep publishing it. You can put another meta-analysis, but it's good stuff. I actually love this paper. Anyone should read in terms of where they are. What they did was, rather than do meta-analysis, they actually looked at the literature across the board and then sort of reviewed every paper and then made comments on it, which I thought was pretty good. Looking at ALIF and XLIF at L4-5. So any of you guys want to read a good paper in terms of comparing, this is good. Again, fusion rates were great across the board, right? And then you follow it, both XLIF, ALIF, they all look good. They quote these papers that are there. So they were directly quoting papers and the results. Fusion rates were fine, no big deal. If you look at segmental lordosis, clearly ALIF had much better segmental lordosis than the trans-psoas lateral. And this was across 2 papers, big series, between 4.5 to 4.7 degrees on an ALIF and about 2.1 in terms of increased correction in terms of a lateral, right? That again makes sense. Again, ALIF was superior. Now, you resect the ALL, you could get some more, clearly, to an ACL. But what's important is this. Even after resecting the ALL and putting cages of 20 and 30 degrees, you only get 7 to 11 degrees. Don't assume you're going to get 20 degrees or 30 degrees just because you stuffed a 20-degree cage. It doesn't work. And the reason for that is you go back to the original paper of Akbarne. Most of them had a pedicle subtraction osteotomy, with SPO in the back. So you got to do, if you want that 20, 30 degrees, you wanted ALL resection with an SPO in the back. Then you'll get your 20 degrees. And I think a lot of people have forgotten that. Go back to the original paper of Akbarne. And remember, it was over, I think, 5 or 7 years. And there were only 17 patients. So think was very selective when he did that. And I think we all do ACR. So if you're doing an ALL resection, to me is different from an ACR. An ACR is with a SBO in the back to get you your 20, 30 degrees. That's a great option in terms of getting that. So if you want that, you can do that option, right? Foraminal light, we talked about a quick ALIF and TLIF. ALIF was clearly better. TLIF basically got nothing. It makes sense. You're not going to get a lot of foraminal light on TLIF. You know, you decompress the foramen, which is good, but you don't really increase the height significantly. So again, something to think about. What are you trying to achieve? But it's a direct decompression, so maybe it doesn't matter as much. But the contralateral side, watch it. I've had at least 2 patients with contralateral change in geometry of their foramen by doing a TLIF from this side, and they get pain on the other side. Rare, but can happen. Complications across the board. There's complications in every approach. They're unique. Each one has its own unique complication. You got to know about them. There are some peculiar ones like lymphoseals and ALIFs. It's not that uncommon. I know patients who have had it, and you can get it, especially you start doing higher level ALIFs. Don't forget, that's where I talk about the mobilization, the retraction, the blood vessels you're pulling over. All that starts these problems. Don't do any of that, you're not going to get it. Stay away, find the areolar plane, don't start mobilizing things around. Now, you got a very slick vascular surgeon, you might be all right. Retrograde ejaculation is real. We all know it, 4-5 and 5-1. Obviously, transperitoneal is way more than retroperitoneal. And retrograde ejaculation, obviously, a lateral, you're not going to get retrograde ejaculation. Nerve root injury, urethral injury, interestingly, in this paper, they say it's extremely uncommon. That's the only thing I would disagree. Urethral injury does happen. We published the first 3 right way back. And since then, unfortunately, I do know a few more. I have defended a few more. And it does happen. And it's hard. The only way to avoid it, in my mind, contralateral is sad. Do not put a device through the other side. Do not pass any instrument across the disc on the opposite side. The ureter is sitting right there. And I can tell you 2 of them, I know that's exactly what happened, and don't do that. You just need to go up to the annulus and tease it to allow it to extend and spread and let the dilator do its job. I think that's been wrong in a concept of going across. That's the only thing I stop. Ipsilateral, make sure there's nothing horizontally across your plane. Just keep sweeping everything before you do something there. That's the safest way to avoid it. But unfortunately, it does happen. You're there and can. So be careful about the lumbar plexus. We talked about it. It's just part of the transverse approach. You do get groin hyposthesias. We talked about motor deficits. And most of them do resolve, I would agree. And we talked about time. So it's all about retraction time, keeping it as low as possible to try to avoid that starting to make sense. And you do want, if you're going to go transverse, try to get it done within 30 minutes per level, and that makes complete sense, right? Sympathetic dysfunction, it's there in ALIFs, it's there in laterals. You're going to see that somewhere. There's some talk about it could be higher with ALIF. Again, I'd say the same thing. If you look and sweep everything away, you're not going to see that change. So be careful before you make that first annulotomy, and I think you'll be fine. When you do that blind is where you may get it with a pre-service approach. Other than that, it's fine. Obviously, I told you I'm not going to, I will always disagree. The neural deficit, I think, is more than we talk about with the transverse approach. It is there. Talk to patients. They'll tell you. Be careful. And again, I'll point this paper out. It's a good learning curve. Today, obviously, everyone's got very proficient, and I know people who do fantastic laterals and do a great job with it, so I'm not knocking any of them. But just be careful. It exists, and be aware of it. That's all. If you look at LF, again, at the end of the day, though, clearly, XL is better than ALIF in terms of sympathetic issues, vascular complications, retrograde ejaculation. A lateral approach is way better than an ALIF. ALIF will reduce the plexopathy, obviously, and stuff like that. So end plate preparation, we talked about that, right? Again, the end plate, interestingly, these guys found at 2-3 and 3-4, the end plate was better on a lateral than on an ALIF. And I find that probably is an exposure problem. They must have a less difficulty exposing 2-3, 3-4, right? Where you're way up there, you got to move the vessels right over. So that was interesting. I just found that interesting. I couldn't believe that. I always think ALIF has better end plate. You see it really well. You go all the way back. And no MIS talk is ever without Dr. Uribe. There's another paper of his with a great diagram. I like the diagram showing the approaches there. And again, they looked at that. ALIF showing, this was indirect decompression. ALIF had a 67% increase in the cross-sectional area, right? Lateral has 24 to 33% increase. OLIF has similar increase. So you're getting good foraminal and cross-sectional increase of the spinal canal, sort of testament to the fact that indirect decompression is real, and clinically we've all seen it over the years. And to me, I stage them so I clinically know they got it. They're up and walking, so when I do multi-levels, that's how I convince myself that you get them and walk and they have no leg pain, they got no leg pain. And you know they got better. Trajectory, this I have a problem. That's why I want to bring it up. The fact that you get more intraneural complications because your trajectory is off in pre-psoas. That's really kind of sad. That's like saying you put the TLIF in the wrong place. It's part of the technique that you correct yourself to go orthogonal. So I kind of disagree with this one. I think if you do it right, that's not an issue. And you can't, we've done spondylolisthesis grade 2 and grade 3. It's all about the technique of getting it. I don't think there's any difference between a lateral and a pre-psoas for doing that, for that point of view. Ultimately, you have to go orthogonal to get it done. And again, this is just, again, overall lordosis. ALIF, again, is the best. Lateral is okay. Lateral and TLIF. Posterior spinal fusion in situ is the worst for lordosis. I think we all would agree on that. They're just locking it in, which is where the interbody, I think, gives you that lordosis, unless you're going to do the osteotomy in the back and create that from the back, which certainly you can with the TLIF. So I'm going to say, I think first point is the most important. Do what you're most comfortable with. It doesn't matter. That's much better for the patient. Don't just run and do something when someone told you to do it. If you're really good at the TLIF, do it. It's okay. Lateral, OLIF, pre-psoas, whatever. Do it. Without a question, ALIF gives you the best lordosis. So if you want to get lordosis, create lordosis, you got a 5-1 disc, go for it. You're going to get the best lordosis there. Again, with LF, OLIF, you're going to get a good one, 4-5 and above. You can create lordosis, place it right. OLIF is better, I think, at 4-5, never going transpsoas. You need more, resect the ALL. You need more, do an SPO. So kind of in your head, plan these things when you go pre-op. What do you need to do? If it's TLIF, you're forced to do a TLIF, great. But you need a lot of lordosis or TLIF, do an SPO. Plan on it. Do an SPO with the TLIF. Posterior in situ fusion, I think, is the worst in terms of sagittal balance. I think we all know that today. Not that it doesn't work. Outcomes may be great, but not. And everyone's unique. Understand the complications. They're all different. Just understand them. I just quickly, quick case. SPO, small bowel obstruction, exploding laparotomy, is actually a really good director. Prior fusion, 4-5-5-1, abdominal sepsis. There's no way in hell I'm going in the front. Colostomy and reversal, I'm not. But there's a great patient for doing a multi-level TLIF with an SPO. You'll get the same correction. So have these tools in your hand. That was totally 3-level MIS TLIF, poke screws, everything else. Poke the whole thing down, correct it down. You can do it, right? So you can do it open, it doesn't matter. I'm just saying have the armamentarium that you got to be able to do that. And it works very well, right? On the flip side, your fusion again, 4-1, fused, imbalanced. 3-4 ACR is a great procedure for this patient. Just do a 3-4 ACR on the top instead of a PSO. I would have otherwise it would have been a pedicle subtraction osteotomy. Instead, you do this procedure, lose 100 cc of blood, and you get the same correction, completely MIS. So these are things that you can think about how you apply these things. And at the end of the day, I'll say, if you have a disc, go for it. Your disc is your best friend. I'm always looking at 5-1 as it open. Always, go for it. You can get great lordosis from there. You don't have 5-1, then maybe think of an ACR. But assume where you're going to get your lordosis. That's it. Every procedure is great. Just use it wisely.
Thanks again, Neel. That was a great talk. It's actually a huge, broad topic, and I think you're able to distill it down to like a 15-minute talk, so that's fantastic. I think we said it earlier. To be a spine surgeon in this day and age, I think you need to be facile with pretty much every interbody technique because they each have their benefits and disadvantages. And depending on the patient's condition, again, it's very important to individualize your treatment to the patient. You have to just select the best interbody technique that in your hands, obviously, but they all offer pros and cons. So, Neel, I know you've already mentioned a lot of things, like for a single level, you like T-lifts, but is that always the case? I like T-lifts too, but sometimes I'll choose a lateral just because of the segmental lordosis issue. So if I just, again, you could argue whether one level makes a huge difference or not, but at 4-5 in particular, I just think a lateral with indirect decompression is a better option than, say, a MIS T-lift. But that's sort of my bias.
No, I think you raise a great point. I think if I want to create lordosis, without a question, I think I'll pretty much do a lateral. But single level, if I already have the lordosis, I can maintain that with my TLIF. So then I'm happy. I'll go with the TLIF. The thing I like about TLIF is single level. I'm fast. I've done it for years now, 15, 18 years now. So for me, it's the same amount of time, actually faster than doing a lateral and flipping and putting screws or same level. And so the only time I do single level lateral with screws is I don't need a decompression. like patient doesn't need a decompression. It's maybe just a grade 1 spondy, doesn't really need it, or very rarely you do a single level who doesn't need stenosis. Very rare operation. So that's why. That's a single level for me is it's just easier. I'm not saying there's nothing you can do a lateral. I love TLIF. It's just a good operation.
Absolutely. And again, I think it's, last I checked, it's the most popular interbody option. I mean, by far, actually. We talk a lot about laterals and ALIFs all the time, but TLIFs really are the most popular technique. So any questions, Timur, Sama, anyone in the audience? Go ahead.
I was just going to say, you just comment on your use of like intraoperative monitoring, as related to like ALIF or ALIF. Do you use it in those cases, or?
Question, Dr. Nog, so everybody on Zoom.
The question was intraoperative monitoring in ALIFs and laterals and things like that. Well, ALIF, honestly, you don't need it at all, but I always have it because everybody else is using it in the next room. I have 8 rooms going, and everybody's using it. So there's always monitoring in my room. I have no idea what's going on. I don't even look at it, don't even see it. So honestly, if you get good at ALIF, you don't need it at all. The only thing I'd say there is do not retract the psoas. I've seen that with people do a pre-psoas approach, but then they're retracting the psoas. You basically lost all the advantage. The retractor should be above the psoas and let the psoas just roll over. So I don't think you need it, and so I've done it in other countries, never used it or elsewhere. So that's my answer. TLIF, I rarely have it. If I was doing trans-psoas, of course you need it. And even ALIF I do. Actually, ALIF is interesting. I use it more for the vascular retraction if I'm moving the vessels. It actually is a very good indicator if we've been retracting the vessels for too long. It actually works really well. We even have a pulse ox. We put a pulse ox on the leg, and the SSCPs will drop. It's very interesting. So that's the reason I like it.
Yeah, I think there's a clinical component to it, and you could argue that it hasn't been shown to be beneficial per se, but there's also a medical legal component. And in some ways, I think that's the bigger component. I've done personally some medical legal reviews, and I think nowadays lawyers are pretty savvy about looking whether monitoring was done or not. And to them, as lay people, it makes sense. You're not taking every measure to prevent a problem because you're not using it. And it's a hard argument to make, actually. Just intuitively, for the average person, it seems like something you should do.
Just have them.
Right. So I think most hospitals allow it. As long as in these days it doesn't take that much operative time to use them. So it's a good question though. Anyone else?
Someone else had a question.
I had another question in terms of when you're doing your lateral approach pre-psoas. Sometimes you see the sympathetics there and you try to move them out of the way. What do you do when they're just kind of rigid? And the second thing is, you said that you don't retract the psoas posteriorly. So what if that window is still small, even after everything else?
Both great questions. I've seen the sympathetic chain only twice. If you sweep everything away, you rarely ever see it. But good point. You should look down and make sure it's not traversing. It's actually a very thin fiber, and has ganglion on it. You can see it's very unique, as opposed to ureter, which again should move with your peritoneum. If you're swept properly, it goes with the peritoneal sleeve, so it should go. Nothing horizontal should be crossing. Before you make anything, look at it. So that's one. Two, you were asking about the psoas, right? The psoas is not attached anteriorly. Its attachment is posterior vertebral body and the transverse processes. It sits on the body. It just rolls over. You go underneath it and it rolls. If it's a big psoas, you'll see a psoas minor tendon. It's a very specific tendon, a great anatomical landmark. You see that tendon, it's the anterior border of the psoas. Now, if it's a very big psoas, you can go between the minor and the major. There's no nerves there. There's absolutely no nerve in that plane right there. It's 4 or 5, sometimes you might have to do that, but that's okay. Just the minor tendons is there. You'll get a little groin pain that lasts for a couple of days, it goes away because you move. That's the best way to do it. But you don't have to move the psoas. It's not attached anterior. A lot of people go look at the MRI. Never attached. It's attached to the back. It rolls.
So, that's a very good and detailed explanation by Neel. And anatomically, he's always great at that. And I just want to let everyone know, if you're not aware, that he is actually the editor of Gray's Anatomy. So you should understand the anatomical structures actually better than anyone here. So I think if there's no other questions, we'll